Hi everyone.
Welcome to our podcast, Health Data Decoded.
I'm Ed Hill.
And I'm Samuel Ball.
We are researchers working at the University of Liverpool in health data science, and we are part of CHILL, the Civic Health Innovation Labs.
CHILL's an interdisciplinary team of researchers, NHS staff, local government and charities looking to use data and artificial intelligence to improve health outcomes in a responsible way.
This work, as well as bring innovation and improvement to health, can also help with our social well-being and the economy.
In this podcast, we'll be interviewing collaborators, researchers and professional support staff within CHILL to better understand what they do in their roles to improve health outcomes for the local area.
We'll be delving into questions such as, what are their day-to-day tasks? How did they get into the role that they currently have? And what advice would they give if you are interested in getting into this area of work yourself?
So join us in our journey to understand better how we can use data to tackle global health challenges and local ones within the Liverpool City region. Hi everyone, welcome to Health Data Decoded. I'm Samuel Ball.
And I'm Ed Hill.
So today we're joined by Laura Bonnett, who's a senior lecturer in medical statistics and the programme director for our MSc in Health Data Science. So thank you for coming.
No problem, thank you for inviting me.
It's great that you're able to join us today. And so with your role, so you've got research and teaching responsibilities as part of your role. And so if asked by others, how would you describe say what you do?
Yeah, it's a really varied role, isn't it? When I first came to the university, I was research only, so that was nice. You came into the office back before we did all this hybrid working, sat at a computer, analysed data, lovely. And then things move on and you progress. And so now I kind of do 50-50 teaching and research. So I spend a lot of my time helping students with content, helping lecturers prepare content, delivering content for our MSc programmes and our MRes programme, and then a lot of my time trying to bring in grants and write papers and support researchers to take analyses and do some research side.
That's it. And as with other guests we've had, where we just have perhaps quite a shortish job title, but then you unpack the layers behind it and there's so many different strands there.
And I think that's why I like higher education and academia actually, because I go into schools quite a lot and do outreach and people say, oh, what's a typical day? And you're like, there's no such thing. Some days it's full on research, some days it's full on teaching. Like today I've got a box out of the cupboard and I've put in a soft toy snake, some post-it notes and some other random goods because I'm about to do a talk for some families, and it's just so nice that every day is so different.
That's really cool.
Yeah, it's interesting because I think when you think of a lecturer or an academic, you kind of think that they're either one or the other. But to be honest, really all of us kind of do a bit of everything, and we just have to kind of justify ourselves at the end by saying, oh, well, these are all things that we've done, and some of them fall under research. But so you're a medical statistician. I think that's really interesting because I think that that's quite a hard concept to think of, and especially as our department's got so many different medical statisticians in.
Yeah, absolutely.
What are your kind of specific research interests? What do you kind of study when you're doing your research?
Yeah, so I always preface, I'm a medical statistician but have no medical knowledge. It's only gleaned over the years, I'm definitely maths at heart. But for me, I'm interested in predicting the future. So that might be through developing clinical prediction models, it might be validating models that already exist, or it might be rolling models out into clinical practice, which is something that people don't tend to do. Dare I say, people build prediction models because it looks nice on the CV to get another paper in there. They might validate them for a paper, but trying to get it then from that journal article into clinical practice is really hard. So I tend to do quite a bit of work evaluating whether we need more prediction models, what they should look like, how to make them into Shiny apps or web-based tools or other systems, and how to integrate that into actual clinical practice.
That's the translation step from the theoretical side or initial application work to then to get to an end user to actually deploy it in the mainstream. That's just another entire skill set, isn't it? Which is
absolutely
learned through time.
And it's not something that we are very good at doing. I think people kind of go, okay, I know how to build a prediction model. I run this code, I do this process. Hey, presto, I know how to write it up for a journal article. But then you speak to clinicians and patients and go, oh, here's a prediction model in a paper. And they go, it's nice. What do I do with it? How do I use it? And so, it's a whole world entirely to try and move that calculator from paper to something interactive.
And with, say, the current proliferation of artificial intelligence tools, etc., and so within the data science and applications in healthcare, do you have a perspective on how things might go? And perhaps with this, actually, with methodologies being or produced now, then ultimately being actually usable by the clinicians and medical staff in the future.
And it's really tricky because I've been in this role for quite some time now, and we talked in the early days about moving away from a single Cox model, so a model that looks at time to first event. And we talked about, well, why don't we look at all the events that happen along someone's journey? And clinicians generally go, ooh, that's different, that's new. How do we cope with that? So I've spent probably 10 or 15 years trying to persuade people that we should look at all events. And then, of course, AI has exploded in a really good way, and clinicians are like, I still quite like the Cox model. Can we still stick with time to first event? And so there's a massive amount of work to do to encourage people to try out the new and to trust the new, because ultimately we are gambling with people's lives here a bit. We're building a model. I can sit at my computer and type some code and I can get an answer. But the clinician has to deliver that answer to the patient, and that patient's life is going to be affected positively or negatively. So it's all, for me, about trust. And I don't mind whether that's trust of AI models or whether that's trust of standard statistical models. It's about building up that trust and knowing that the information we're sharing with patients via clinicians is reliable.
It's really interesting, isn't it? Because I think that the explosion of AI has kind of made everyone really think about how do we deploy these safely and transparently. And one of the interesting conversations I've had very recently with NHS trusts is essentially they're coming to the table now and they're saying, here's all these shiny LLMs or large language models or kind of agentic AI solutions, and they're very shiny. And my background is in the kind of deep learning-y shiny things, and I kind of sit there and I put my hand up and I go, well, hang on a minute, what about the statistical models? Have you thought of using that? Have you thought about the expert systems that are just like a flow chart? How do we build a framework for safety that allows for those not shiny models that are kind of being pushed now to just be the only thing that we evaluate? And we need to evaluate the kind of normal models as well.
Yeah, and there's a fundamental problem that we need data. And electronic health records are lovely and beautiful, but I work in chronic conditions that are typified by specialist centres. So the Walton Centre here in Liverpool specialises in neurosurgery and neurology. They're still on paper-based records for most of their epilepsy clinics. So as much as I can do, really amazing modelling, it's based on paper-based records. So it's not like I can all of a sudden go, oh yeah, we'll build a model, it'll run behind the scenes and spit out an answer. There's some really fundamental things to fix first.
I think that really gives that's conveying, you've got to think about what is the available data, what additional data might help you analyse the problem, but then given that, therefore, what is then a reasonable model or type of approach to use, which will then give you an outcome which you feel reasonably kind of confident in or would be reasonably supported, and it's not we're throwing a model at it where actually we don't have the relevant data for the output that's given to be anything beyond just massive uncertainty, which then means you can't actually give an informative decision at the end.
Yeah, you don't want anything that's got such wide confidence intervals that it's like you might have 10 seizures in the next year, but it could be anything between 0 and 100, so it's just not useful.
As a diagnosis or as a clinician, that does not sound helpful in that setting.
And it's funny as well because the problems that we're having with AI at the moment, especially in healthcare, a lot of them aren't new. It's stuff that the statisticians have been talking about for a long time. And when we do research into uncertainty of medical imaging, and we look back at the clinicians' need to be able to reason and say there's a 95% chance, and the model's perhaps unsure in this case, so I'm going to use my own professional judgment. In AI, we're 20 years behind, and you've got a medical imaging model, and you go, yeah, that patient's got pneumonia, and you go, oh, why? And it goes, I don't know. I'm just going to tell you yes or no. So I really think that the AI circles and the comp sci circles can learn a lot from statistical modelling in terms of how you approach these from a clinical point of view.
Yeah, absolutely. And I kind of hate all this compartmentalisation. It's really important because we all have different terminology, but There's no reason we can't all collaborate and work together. A lot of what I do on the MSc and the MRes programme is about communication skills and the fact that we all need to be able to talk different languages. If I'm talking to a patient or a patient user group compared to a clinician group compared to a bunch of computer scientists, we all need to understand what we're talking about, because if I talk about statistical models and AI professionals talk about, algorithms, we need to know that they're kind of the same thing. And so there's that whole language barrier to deal with as well.
Yeah, I think that's really interesting. And I think it brings us on to the next question really well. So we kind of talked about the research, but then it sounds like teaching became more and more of a prominent role in kind of your work. Can you kind of explain how that journey kind of came about and how you got into teaching in the first place?
Yeah, so I've always kind of loved helping out and guiding people to understand better. That could be somebody who's perhaps got less experience than I have, or somebody who's learning a new topic. I've always enjoyed the whole, there's no silly question, let's just work it through. And so when I was early on in my career, I was given the opportunity to help out as part of the CPD courses that the Department of Health Data Science runs. Kind of enjoyed that, but felt really like a fish out of water. I was stood in front of a group of people who were much older than me, and we're all clinicians and knew their stuff. And I was kind of standing there as a junior statistician going, you can do a hypothesis test, I think. And I was like, this is ridiculous. So signed up to do some of the training that the university offered, became an associate fellow of the Higher Education Academy, and kind of felt like I'd got a bit of a skill set. And then it kind of spiraled from there. We did more CPD. We then, as a department, decided to run an MSc program. That's now 2 MSc programs and an MRes. And it's kind of something that I really enjoy doing. Especially now we have the conversion programme for students who don't have prior skill in statistics or computer science or maths. Actually, I love that challenge. We have, in previous cohorts, had a geography student. And it's lovely to be able to go, okay, you've got knowledge, that's fine, we'll work with that knowledge. The ability to learn is actually far more important than the fact that you know what logistic regression is or whatever. And so I've really enjoyed that challenge, and kind of from there have I say upskilled, that sounds very grand, but adapted to the students we have and tried to pick up extra training as we go. We have a lot of students currently who have support plans and English as an additional need. So we've looked about how to make our rubrics accessible for all students. And I'm currently investigating some training courses that I might do in terms of making our lectures more accessible for students with additional needs. So.
I think it's a particularly interesting point about the conversion course. I think we always asked, and we're going to ask you in a moment, what the background is in terms of how they kind of got into the role from the first place. And I think we're always surprised about the backgrounds people come from, and they might have studied something completely different before getting into health data science. And what we often find is actually it's a value add. If someone's got a degree in geography or history or something, there's going to be some lecture they sit in and they go, oh, well, actually, this is what we've learned from geography, the humanities, or something completely different. And you bring that into the health data science context, and it's really valuable to have because it's such a wide. When we talk about, and we kind of talk to students about the different routes into health data science, we've got this Venn diagram of all the different kind of comp sci, maths, medic, kind of to bring it all together. But really, it's almost the wrong way to talk about it because anyone can get involved, and it's all skills that are valuable.
Yeah, and what we're really after is that spark. It's much easier to teach someone who is interested in the topic and has motivation for that topic than it is to teach someone who did absolutely amazing at a maths degree and goes, I'm going to do a master's degree now. It's not as fun from my point of view either. I really love going, okay, that's your interest. Let's help you build on that interest. Let's pick some modules that are going to help you to lead to a dissertation on your really interesting point, and then we might be able to get a publication and a job. And, that for me is where it's at.
And remarking a bit on that, so you get the situation of someone might be able to excel at statistical, mathematical type problems, but then as you enter the more research realm, more within teaching, it's a bit more collaborative in that sense. So there's more conversation, not just one person on their own, and therefore they might excel at answering, but if they're not actually that interested in it, therefore it makes the conversational side much more challenging. So I think I'm with you where someone who's keen and interested, it's like that makes it a workable relationship essentially. And then from the research and training and teaching standpoint, I think it's much more than beneficial.
Yeah, absolutely. And we've been really lucky to build a program from scratch, and so we have obviously the talk content in all the different fields that you need, but we also offer like consultancy skills, communication skills that I mentioned before, and lots of add-on stuff that I think people just assume. Back in my day, you did an undergrad degree, you might have done a master's, you then did a PhD, and somehow in that process you were expected to learn how to talk to other people, how to give a presentation at a conference, how to write a journal article. You wrote something, you sent it to your supervisors, they obliterated it, and you did it iteratively for weeks and weeks and weeks. I think if we can take some of that fear away by teaching a bit of how to give a presentation, how to do a poster, at least students leave the course as a graduate with some skills behind them.
That's it, though, and they're transferable skills as well, which are then usable across many different job roles, etc. So
yeah, absolutely.
I think that can be super powerful. So with your current teaching-based responsibilities and with the courses that you're involved in, so there's various different aspects that can range from the recruitment side to the actual design of the courses to then the teaching you do itself. So on that, what is your involvement, and with also potentially having to manage a team as well to help you deliver these programs?
Yeah, so it's really interesting because I used to be a module coordinator, which was nice. You were in charge of a module, you have 12 weeks to kind of sculpt as you like, delivering some content, sharing content with other people, marking some assessments. And that's kind of a really nice way into teaching at postgraduate level. From there, I then became program director. So not only am I in charge of a couple of modules, but I need to oversee an entire set of modules that involve optional modules and core modules. Mm-hmm. And that meet the requirements of the programme and at the right level. And so there's a lot of work with quality teams and scrutiny boards to try and ensure that that is appropriate and any updates meet that. Then there's the elephant in the room of getting bums on seats, and it's a horrible phrase, but it's so true. There is no point having brilliant teachers and amazing content if you've not got students in the room. So a lot of what we do is kind of do a multi-pronged attack on marketing. We're trying to recruit international students, home students, those with maths backgrounds, those without maths backgrounds, CPD options, because you can do all of our MSc modules and our MRes modules as CPD route as well. So it's just kind of throwing the kitchen sink to try and get people on the programme. And then for me, probably the most interesting bit is the students who are not perhaps coping quite as well as they thought they might. So the pastoral side of things, maybe students are not coping with the timetable or with their time management for assessments, or maybe the content is just harder than they thought. And so we have lots of progress meetings and pastoral meetings where we try and help students to kind of get through to the end, not just get through to the end, but doing really well. We had a student last year who in semester one wasn't really coping very well and didn't do very well, but in the end they came out with almost a merit. So we were really proud to have got them through that.
That's it, and that the support role that's offered, I mean, that's so crucial. And then ultimately you'd like to be contributing to their journey to move on to the career they would like to enter in on after they've completed the masters.
Yeah, absolutely.
I think one of the advantages that health data science as a department has is because we're so small, that one-to-one development is possible, whereas in a larger kind of university department, it's kind of much more on rails, the kind of experience. And I think there's a case for both, but I think we get a lot out of speaking individually to students.
Yeah, I think if you're going to run a conversion program in particular, you need to have that small cohort. You need to know your students because, I've been privileged to get to know all the students across all the cohorts we've run, and I'm still in contact with all of them, and I still get requests for either, if they're looking for promotion and they want a reference for that, or they want to ask something about something they're doing at work and want a bit of stats guidance. And I love that we have that relationship with our students, and I know many of our supervisors have the same with their dissertation students. And that is so important. You're coming to a new country in some cases, you're doing a master's degree for the first time, it's in a topic that you've probably not specialised in before, it's all brand new. And if you've got those named points of contact that you can go to and go, I don't understand what's going, how do I do this? And I'm really privileged to be able to be the one on the end of the email, at the end of the phone and go, yeah, we can sort that. Okay, talk to me, we'll sort it out. And I love that.
Yeah, brilliant. So I think one of the funniest things about the academic journey is that you kind of take all these like little side adventures. I mean, my favourite one is because my PhD was in drug discovery, really. I was actually in the lab and doing cell culture, and I've got no biological background at all. So you're only supposed to grow these cells and split them like 7 or 8 times, and I went to split number 100, so they're something completely different. So everyone was kind of laughing at me in the lab environment. But that's kind of the adventure of it. So it's like, what kind of skills did you learn that you didn't expect to learn in your career that you've picked up?
Yeah, and I think that's a really interesting point. As a slight aside, I know your pain with doing something slightly different. I was supervising a group of students and they were giving presentations, and this one chap at the front kept talking about Brian the shrimp. And I said to him at the end, why did you decide to name the shrimp Brian? And he was like, it wasn't Brian, it was a brine shrimp, as in saltwater. And I was like, yeah, this is why I shouldn't teach outside of my topic area, but hey ho. So yeah, as you say, side adventures. For me, I think I've definitely upskilled in people management, whether that's pastoral support through teaching or trying to help people negotiate new contracts, get their first paper, deliver their first oral presentation at an international conference. It's those sorts of things. We don't really get training any of that. You just kind of get thrown in at the deep end and go, you've got a team now, go. Ooh, help, what do I do? And, I've definitely made some errors in that area that I've kind of learnt from. And I think it's just really important to be kind of open to people and go, I'm new at this, I don't exactly know what I'm doing, but I know that I've got your best interests at heart and we'll get through it together. And I think that's always been my kind of attitude towards anything, really.
Cool. I think that's a very progressive, right, constructive approach to take for sure. And yeah, I think I'm very much with you with that in terms of helping people manage, etc. That just being yep, have a go, see what happens. And something else we're all going to be collectively just experiencing. So with the kind of the boom in artificial intelligence type tools, etc. at the current time, and so thinking about the teaching aspects. Do you have any thoughts on, I guess, perhaps delivery of courses or the teaching of students and their use of artificial intelligence tools might impact things in the upcoming years? And then, longer term, we might be training people for jobs we don't even know will exist in 10 years' time, I suppose. So it's how careers within the health data science sector might develop.
Yeah, it's really interesting because 5 years ago, I would have said I was very anti-artificial intelligence. I didn't understand it. What was wrong with the logistic regression model? I mean, why do we need artificial intelligence? I do now see definitely the benefits of it, and there are certain things that I find very useful to do. You've written a journal article, it's too long. Generative AI can help you reduce it to a sensible word count, rewrite it in a slightly different tone. There are things that it can productively do. From a teaching point of view, though, it's a nightmare because there's nothing to stop a student typing in, please, can you write my assignment for me? And it spits it out. So we're behind the curve across the higher education sector as to how we deal with that. And that's an uncomfortable position to be in. I don't like being behind the curve. How do we now write assessments that are generative AI proof, if you like? I don't think we can. So this is our opportunity to now think completely differently about assessments. How do we design things that people use AI appropriately and robustly, but still prepare them for real world? Because you still have to submit journal articles that you've written. How do we teach them to write that text in the first place that you can then put into generative AI to improve it? And that's where we're kind of struggling. So the world is going to evolve much quicker than we're going to catch up. We're always going to be behind for a long while to come. But there are going to be new roles, there's going to be new jobs. But ultimately, I think, she says naively, we're always going to need the humans behind that. It's always going to need that interpretation, that checking, that intuition that even the best AI currently hasn't got that human element. So I think we'll be all right for a bit to come. Yeah.
It's interesting. So for my module that I teach within the MSc, I say at the start, you can use generative AI. In fact, you have to for the last 2 weeks because we kind of code it. But if you do it, I still think it's blindingly obvious when a student has given you something with generative AI. And my this is perhaps a little bit too controversial for the podcast, but I think if you can write something with generative AI and I read it and I say I can't tell whether that's generative AI or not, and it's still hitting all my bits on the rubric, then I'm kind of like, well, fair play, because you've used it in a way that has produced something that is of the required standard to get there.
Yeah.
But when you lazily use it and you do the thing of you type in and you say, can you write it for me? And it goes, there's so many patterns with like M dashes and patterns in language that if you use it lazily and not properly, I think it's quite clear.
Yeah, and it's how do we convince the nation that you have to do those steps, you have to understand what it spits out, that it has to be plausibly your language, and I think that's really hard to teach. It's a bit like teaching common sense. It's not something you can do. You can help people manage their time, you can help people plan assessment deadlines, but ultimately you can't teach them that they actually have to put in the work. They kind of have to not put in the work, do badly, and then have that moment of, oh, bother, I actually need to do this. We kind of need to offer university, I think, that safe space to get it wrong, to go, okay, write my assessment for me, and then them get involved in sticky water in terms of generative AI misuse and investigations for that. Because I think unless people have had their fingers burnt, it's much harder to try and go, you could do that, but that would be a bad thing to do. Instead, you need to, and I don't know how we do that proactively. I don't know how we just go, yeah, do what you like, we'll tell you off, and then we'll start again. I don't know how to preempt that with, don't do that, do this instead.
I think when we do project work with students, it's clear when we're developing it and they do something, it's like, well, you've not actually answered my question here. It's like, and then you start to ask questions of, oh, have you written this yourself? Can you tell me what this means?
Yep.
And those questions are quite interesting, because when you get a student to explain themselves, I think that's when it becomes clear. And that, in a way, is the learning moment.
Yep,
not just from the, should I use generative AI, but also if they can explain in their own words to me what they're doing, that's something that we've been doing in teaching for decades.
Yeah.
So it's still applying old techniques, but within the new context, which is quite interesting.
Yeah, we have an assessment now where we ask students to generate a data set using generative AI. Wow, we ran it for the first time last year, and I had more emails and queries about that assessment than any other assessment ever, because they were so terrified of using generative AI that when I said, just use it to generate a data set, here's some example prompts, but go away, create, they were like, but can it be like this? Can it be like that? And, so I think there's kind of two areas to this. There's the misuse, and then there's the appropriate use.
Yeah.
And we need to get much better as a sector, really, at trying to teach both those different components.
Yeah.
So in that very fluid time right now where it's in the state of flux and we're all going to be collectively on this journey of as things move on.
Yeah.
I might settle down.
So I think the last question we like to ask all the guests on the podcast is, say you're a person, you're listening to the podcast, you want to get into health data science. What would be your recommendations and how people can get involved?
So I think we're all already involved. I know that sounds interesting, but I'm just in the process of preparing a talk where I talk about the data behind your medicine cabinet. And I make the point that moment you buy a new box of paracetamol from a supermarket, you've already contributed to health data. So we're all in it. But I think it's about that increased awareness that moment, that booking of a GP appointment, that purchase of a repeat prescription, that's contributing to data, and that's contributing to health data science. And for me, that's lovely. We're all involved in it all the time. So it's about changing it from, I'm just going shopping, to, oh, I've contributed some data. I wonder how that data's used. I wonder how I can trust that my data's being used responsibly. Oh, if they're going to use it, I wonder what the results are going to be. I wonder what predictions come from that. So I think it's about asking those bigger questions, finding out more. By all means, go online and search for more information. Listen to people talk about stuff. Read stuff critically. I think often people read articles. I've got some teaching examples of old newspaper clippings where there's some really dodgy graphs of things, Divorce rate over time, petrol prices over time. Hey presto, as petrol prices increase, divorce rates increase. It's not. There's time going on in the background. But it's about looking at those newspaper articles and those graphs and going, does that make sense? What else might be going on? And just having that critical mindset that can turn us all into health data scientists as an entry level.
Yeah, brilliant. Well, thank you, Laura, for coming onto the podcast, and thank you for listening. If you like today's episode, you can subscribe on Spotify or on YouTube, and we'll see you next time for the next episode.